Very warm good evening and welcome to all the participants and all the faculties here. Hereby today we welcome you to a very interesting webinar on liquid biopsies, its role in therapy monitoring and cancer diagnostics. Today we are joined by one of the very esteemed speaker, Dr. Shyam Agarwal, who is the chairman at Sir Gangaram Hospitals. His experience and esteemed approach to have new uptake new technology in cancer treatment is unmatched for. So first session will be by sir on the clinical aspects around clinical experience on the liquid biopsy, and followed by which the second session will be by our own Dr. Suruchi Agarwal, who is our head of scientific affairs and has esteemed knowledge and technical experience around the laboratory experience in liquid biopsy testing. So we'll be taking the questions at the end of the session. We will request you to just keep sending the questions in the Q&A, and at the end of the session, it will be open for discussion. Thank you so much everyone for joining, and please, I'd like to extend my warm welcome to Dr. Sham to start the proceedings.
Thank you, Dr. Charu, for those kind words, and thanks to Medgenome for organizing this webinar, which is going to be focusing on liquid biopsy. So I bring greetings from Sir Gangaram Hospital, New Delhi. So this is the outline. We're talking about introduction and some examples as to what kind of work is going on in ctDNA in a few cancers, and then the take-home messages. So next slide, please. So I've taken the help of ESMO Oncology Pro to prepare these slides and certain other, resources. So this is how the liquid biopsy is. That is, there are several components when you're looking at liquid biopsy, which basically means that you're looking at the blood which is detected or drawn from the patient, and then you're looking for circulating tumor DNA. One can even have tumor cells which are shed off from the solid tumors, which is like CTCs. They could be tumor cell vesicles and circulating tumor RNA. So and maybe there are other parameters also which can be looked into the peripheral blood. But today, the whole focus is going to be on ctDNA. So basically, these liquid biopsies, they permit us to have an access to tumor genotype and phenotype with low harm, in the sense that you don't need a, biopsy or a cut or into the tumor, because that is what biopsy entails. And I think the most prevalent of these is the circulating tumor DNA. If you have to take, these four parameters into account. And basically the tumor cells, they are undergoing apoptosis at regular interval while they are dividing and multiplying and metastasizing. So from the circulating tumor cells, as a result of apoptosis, the ctDNA, which is the DNA which is released from the circulating tumor cells, is released into the peripheral blood. And that is what this simple, a blood sample is going to pick up. I mean, that is the whole, it's quite easy to sort of, and the interesting thing is that if you look at these different colors, because there is so much of heterogeneity in the tumor cells, so these tumor cells are going to be, I mean, they're actually different when they are proliferating and when they are dividing. So they acquire more and more mutations and abnormalities in the DNA. And so in the blood, you will get the ctDNA, which is shed off from not one kind of type of a tumor cell, but from, all these red or green or blue or these colored, So that's another advantage of this picking up of the ctDNA. So it basically contains diverse tumor cells and products shed off from the multiple tumor sites. So you can see from the lung or from the liver or from the primary side. So these cells can be, they are shedding off these, DNA, which is going to be picked up in the peripheral blood through a syringe. Next slide. So this is an interesting slide where you can see that in a patient's blood, the wild type or the normal DNA will constitute something like almost 99% plus, and the tumor DNA fraction, which is the mutation or the containing the harboring the mutation, is a very, very small component of the entire DNA if you were to segregate it from the blood. But what is interesting is to see that there are some tumor types which really, the frequency of cases with detectable ctDNA. So you see the bladder, the colorectal, the gastroesophageal, ovarian, and to some extent pancreas and breast. So, majority of these patients' blood sample is going to be containing ctDNA. Whereas if you go down into the list, for example, prostate cancer or neuroendocrine tumors or medulloblastomas or like brain tumors, renal cell carcinoma, thyroid and gliomas. So there the ability of the technology to pick up the small fractions of tumor mutant DNA is going to be much lower. So I think one needs to keep this into mind when we are trying to look at the various research aspects. So I mean, you need to perhaps select out patients where there is a higher frequency of cases with detectable ctDNA. So where you're going to get more positive results than as compared to patients who have prostate cancer or renal cell carcinoma or even head and neck cancers. So this is another important factor which we need to keep in mind when you are doing research or working on these tumor samples. Next. So now, what are the various platforms for detecting ctDNA? So as you see, you need this plasma for DNA isolation because that contains the circulating free or the cell-free DNA. And so various techniques, as you see here, Sanger sequencing, real-time PCR, and then came, standard NGS. And if you were to look at the assay sensitivity, it keeps getting better and better with the newer technology, which includes, ddPCR, digital droplet PCR or beaming, or the, the more latest comprehensive or CJP NGS, where the assay sensitivity comes down to 0.1%. And when you come down even further to CAP sequencing, which is personalized sequencing, there the ability of picking up the tumor DNA in the peripheral blood is down to 0.00025. So, this technology, although a little tough, but we have certainly come up to this level in very frequently. But then the CAP sequencing or more personalized, ctDNA detection is cumbersome and has false positive and maybe false negative because there's going to be a lot of noise while detecting the mutants in the peripheral blood. So for metastatic cancer, so these technologies, the upper, you can see are reasonably sufficient. When it comes to picking up stage 1, 2, or early stage cancers, and even maybe pre-neoplastic lesions, say then you need to go to modified NGS or CAP sequencing. So I think we certainly are at this level at the NGS and maybe the CJP for even doing the ctDNA detection. But this part, I think a few labs have mastered it or trying to master it so that it can be applicable to early stage non-metastatic cancers. And for example, people are focusing on individual mutations, which are more common in solid tumors like KRAS, BRAF, EGFR, ESR1, etc. So, one is focusing on individual mutations, when it comes to very deep sequencing in order to identify these mutants. Next. Next slide, please. So these are some differences where liquid biopsies, offer advantage over the tissue. But then, so these are the uses of ctDNA in cancer treatment. So now you can see the cancer detection screening or earlier diagnosis. So usually, tumors start with, one clone, and over a period of time, there is a second clone. So one does some kind of surgery here. And when you have removed this, so you may have no detectable mutation in the peripheral blood. But then if there is something in the peripheral blood in terms of mutant DNA that can help decide you the therapy, and you can monitor the response by looking at the VAF or the allele frequency of the mutant. And therefore, you can do serial liquid biopsies and monitor quantitatively. For example, if somebody has KRAS mutation, so you can quantify that in the beginning of the treatment or before surgery and after surgery and so on, and see how the mutant allele frequency is decreasing or increasing, which can tell you the quantum of the disease in the body of the patient. And once the patient is becoming resistant, so as you see, this was the original clone, but when patient is having extensive, aggressive, progressive disease, so the second clone takes over and new clones appear, the dark blue one. So which can be picked up, by the ctDNA technology by a peripheral blood. So, this is a scheme which can maybe a guide in terms of how to involve yourself in research with using ctDNA or the serial liquid biopsies. And this can help you in deciding the treatment, monitoring the response, and monitoring clonal evolution. So once you have understood this, then it is just a matter of applying it to the patient. And, and of course, the technology has to be very, very robust and validated so that whatever you're picking up is actually true and it's not false, or you're not missing, because the amount of ctDNA which is going to be present in the peripheral blood is going to be variable depending upon the stage of the disease. In the early stages, the quantum is going to be less, and therefore you'll require deep sequencing like cap sequencing. But if you have a lot of disease in the body, well, then the standard techniques should be able to pick up. Next. So then another question which is frequently asked as to what is the concordance between the ctDNA obtained from the tissue or the solid biopsy tissue then as compared to the sample which is taken in the peripheral blood. So now you can see that the concordance between, or the type of agreement between plasma cfDNA and the tumor tissue is, hovering around 82%, 87%. However, there are complete disagreement in 13% of the patients. So there are advantages of doing the liquid biopsy, whereas because the liquid biopsy, which contains the ctDNA, is representative in a patient with metastatic disease from the DNA may be sort of shed off from lung metastasis, liver metastasis, bone metastasis, and the clones could have evolved. And you will pick up, more and more abnormalities. Whereas in a patient, when you're doing the tissue, so you're obtaining tissue from, say, only one organ, and you may be looking at one or two types of, mutations. So I think there are subtle differences between plasma and the tissue, and there can be sometimes, complete disagreement in 13% of the patients. So you need to understand this concept. Next slide. So, this is like cross tumor type actionable mutations in plasma. One can see that, nearly 60% of the patients or more will have more than one alterations. So which, brings us to the point that tumor evolves slowly over a period of time, and patients accumulate mutations in a variety of genes. And there are several common actionable mutations like P53, EGFR, MET, PIK3C, Notch1, and in brain, in lung, in breast, and GIT, there could be different mutations, but there still be commonalities, as you see here. EGFR and P53 and ERB2, etc., are common in a variety of cancers as they evolve, and so you can get this kind of a report. So I think by and large, what it is said that in a given patient with metastatic disease, there are about 10 or so driver mutations, although they are harboring more than 100 mutations or abnormalities. Next. So these all can be picked up on the ctDNA next generation sequence. So coming to colon cancer, which I told you is a cancer which sheds ctDNA into the peripheral blood. So one can use this in the adjuvant setting. One can use this in the metastatic disease. So we'll just come to that, and we can use this in monitoring of the response and resistance. Next. So this is these are recent data, not very recent, but 2-3 years old, where patients of colon cancer with stage 2, 3, who are operated upon, which is post-surgery, and you were to look at the ctDNA, which is negative, and this curve represents ctDNA post-operative, which is positive. So look at the outcomes here. So only 10% patients who have ctDNA negative, they relapse, whereas patients who have residual ctDNA in their peripheral blood, 78% patients will relapse. So look at the significance of ctDNA, which means that in a patient where disease was just confined to the colon, after removal, there are cells which are left behind in the body of the patient, which are responsible for shedding this ctDNA, which is picked up in the liquid biopsy. So they therefore need more treatment. Similarly here in stage 1 to 3 post-surgery, patients who are ctDNA positive, 70% patients are going to relapse. So, this technology can help you take a decision whether a patient needs adjuvant therapy or not. Of course, the trials are ongoing at this point in time. It may not be that simple, but it's a very, broad concept here that patients who have a ctDNA negative, they may be spared of chemo. Mind you, they may be spared of chemo, but which are those patients we still need to figure out, because they have a good chance of cure without chemo. So you can remove chemo in these, but however, anybody who's ctDNA positive after surgery will require adjuvant chemo, all of them. Next slide. So that's the impact of detecting ctDNA after the surgery. The similar curves here, you can see. You can do the mutation tracking in serial plasma samples, and patients who, for example, continue to harbor after 3 months, 4 months the ctDNA, well, they're bound to relapse. I mean, they're likely to, 87% are going to relapse. So if you have serial samples, and this is what a lab called Signatra does. That is the serial sample monitoring, testing for the presence or absence of mutations in the peripheral blood by looking at the ctDNA. Next. So all these people who are ctDNA positive will warrant adjuvant chemo, but we haven't reached that stage because the ability of these techniques to detect, this kind of in early stages, I think we need deep sequencing. We'll just come to the project also. So now the correlation of the same thing which I said, tissue ctDNA with the liquid biopsy is high, but still discordances may happen. So you can see here, the positive agreement is in 96.4%, negative agreement is in 90%, whereas overall agreement is in 93%. So which means that 5 to 7% of the patients, there's going to be a discrepancy between the tissue and the liquid biopsy. And we have to, keep that in mind while taking decisions. Next slide. So now, as I said, for metastatic disease, one can monitor resistance to anti-EGFR monoclonal antibodies like cetuximab or panitumumab in a patient with, KRAS negative, because that is where, or NRAS negative, that is where we use these anti-EGFR antibodies. And here is this one curve here, that patient starts treatment in August 2009, and the patient is KRAS negative, and patient is given the drug, which is cetuximab. And when the patient starts, stops responding, and then the KRAS mutation is detected, and therefore the antibody stops working. So, I mean, appearance of the KRAS mutant clone can predict relapse or lack of response to anti-EGFR antibodies. And this is what you see here, that initially the patient is responding, the CEA levels are coming down, and the liver lesions are responding. This is the partial response to cetuximab. But then when these mutant clones of the KRAS, they start appearing, the tumor and the CEAs, they start rising. So this is another similar curve that when you treat them subsequently with another drug, or for example, initially you're given FOLFOX with cetuximab, and then you give FOLFIRI with BEV, the clone, this particular clone will come down, and patient will become, again sensitive to cetuximab, and one can re-challenge, and there can be efficacy of cetuximab or anti-EGFR antibody once the clone of the KRAS mutant has declined. So this is, and the patient starts responding again. So that's the importance of monitoring, the KRAS clone in a patient who is being treated with anti-EGFR monoclonal antibody. Next. So this is one such project, we started in our hospital at Gangaram, the next generation sequencing based cfDNA and CTC analysis for monitoring minimal residual disease using liquid biopsies from patients with colorectal cancers. And this is done in conjunction with the MedGenome people. Next. So that is the, again, I bring you to the same point that patients with stage 2, 3 cancers who've been operated, they may be avoided or can avoid adjuvant chemotherapy. But can this be avoided? Because everybody's scared of chemo. So the idea is to determine a minimal residual disease before. So you have to have a sample before the surgery is done, and after the definitive therapy like surgery and radiation. Next. So how is it done? I'll show you in the next slide. So the ctDNA analysis is based on tumor-informed personalized approach. So what you do is you take the tumor tissue after surgery, and the FFPE block is sequencing is done, the NGS is done, and you identify 15 recurrently mutated genes in colorectal cancer. So these are the common genes which have been identified here: P53, KRAS, ERB3, etc., etc. Next. And then in a given patient, then after the surgery, in a given patient, we look at the week 4 and +7 plasma. At least one patient specific mutation is assessed in plasma. For example, in this patient, if KRAS is found to be mutated, this is in the operated specimen. So you look at the KRAS mutation in the ctDNA by the SAFE sequencing system, which is deep sequencing. So if there is, the KRAS mutation which is present in the tissue before has, so you're looking for the minimal residual disease in the plasma. Next. So this is the technical part where the unique identifier is assigned, and the the SAFE sequencing system is applied through amplification and the PCR. So this is where the deep sequencing or the cap sequencing comes into play in early stage cancers. Next slide. So again, this is a similar slide, kind of a repetition that the targeted next generation sequencing comes to 1% of the sensitivity, and the ddPCR 0.01, and the cap sequencing is 0.001% sensitive. So you are not only looking at DNA, but you're also looking at gene fusions. So I'll not go into the details of these, but you can also look at DNA methylation in the cfDNA. Next slide. So these are technical parts. So based on that, minimal residual in stage 2. So this is a publication from NEJM, from Memorial Sloan Kettering, where you can see the ctDNA guided management versus standard management. There is not much difference, but this is still evolving at this point in time because the technology is not validated, so it is non-inferior than as compared to standard management. So, these are early data, although they appeared in 2022. There's an update in this ASCO 2024, maintaining this. But I think these are expensive tests because when you do deep sequencing, I think there's a lot of cost incurred. Next slide. So this is again to show in urothelial cancer, the ctDNA which guides adjuvant immunotherapy, that patients who are ctDNA negative, this is the curves here, and patients who are ctDNA positive after immunotherapy, so the likelihood of relapse is very, very high here. So you can look at urothelial cancers as well, and the efficacy of adjuvant immunotherapy and the outcome in a patient. Next. So I'll skip this slide. This is what I just showed you, the dynamic thing. So, similarly in pancreatic cancer, again, after resection, one can go for detection of minimal residual disease. And this can determine the presence or absence of ctDNA, the outcome in a given patient. Next slide. So as I showed you, gastroesophageal cancers, they also, shed the ctDNA in the peripheral blood. And again, the same concept before resection, and the VAF, which is the serial monitoring, that is the variant allele frequency. So if there is a persistence of the abnormal clone and the ctDNA in the peripheral blood, so these patients are likely to relapse than as compared to patients whose VAF is much, much lower. Next slide, or is absent. So I think ctDNA has come a long way in the detection of genetic abnormalities in patients with lung cancer. So this is, one such patient. Squamous cell carcinoma of the lung, PDL1 is 70%, and MRI brain is negative. Next slide. So this is the lesion which is seen and the bone metastasis. Next slide. So normally you would like to do the tissue, but if sometimes tissue is not available, I think the liquid biopsy can be performed. And you see here the MET exon 14 skipping mutation, which has been reported here. Next slide. So if you look at this, report here, the MET is, if you look at the cfDNA or amplification is 0.5%. So the amount of ctDNA which is present in the blood is so low, but if you detect any targetable, actionable mutation, that patient becomes eligible for targeted therapy. In this patient, the patient can be given capmatinib or tepotinib, and these are the first line therapies for MET exon 14 skipping mutation. Next. So this is if you give this patient the capmatinib, then the tumor has shrunk after a year. Next. So it can really change the patient's life and the longevity, etc. So this is another patient where you see the sense of breathlessness. And the next slide. So again, you see the right lower lung mass with the lymph nodes and lymphatic spread. Brain is negative. Next. So this is adenocarcinoma. Next. And if you look at the insertions and deletions, the EGFR, and the ALA 767 valine is there in the exon 20. Next slide will show you that. So it's an insertion in the exon 20 of the EGFR. And this particular one is not sensitive to TKIs, as you are aware. So you should not be jumping onto EGFR TKIs. And one should think of the bispecific antibody, which is targeting EGFR and MET, which is called amivantamab. Next slide. So today, I think there is a guideline for, this is an old slide, that patient was treated with chemo, and after which the patient developed, you can see the brain metastasis. So currently the guideline is to use for adenocarcinoma carbopem along with amivantamab in the first line itself. So that is the advantage of figuring out whether the patient is having EGFR, exon 19 or 21 mutation, whereas exon 20 is to be treated differently at the insertion. So this patient received, amivantamab in the second line. Next slide. So I think this is another patient which shows ALK, ROS, and FISH negative in the the tissue. As you can see, this is adenocarcinoma with bone lesions, and the TPS is more than 90%. So people would assume or think that because the TPS is very high, so this patient can be treated with immunotherapy. But then it's very important to look at these are the lesions. So this patient underwent a liquid biopsy. Next slide. So you look at the liquid biopsy, there is P53 and this particular gene. But if you look at the bottom, the ROS1 fusion was seen in 0.9%. So, I mean, as I said, although the VAF is so low, but if you have ROS detected, well, then you are supposed to honor it. And next slide. So I think this patient did receive, the drug, the ROS TKI, which is crizotinib, and you see the reduction in the various, VAPs or various oncogenes. Next slide. So you can see the clinical improvement. So, the point is another thing here, that if you don't have tissue, so you should do the liquid biopsy to figure out whether the patient has any of these driver mutations. And there is some data which is evolving that if you do both tissue as well as liquid, as I said, there can be additional inputs when you are doing liquid biopsy. So some people actually start with liquid biopsy. If they don't pick up anything there, well, then they also send the tissue. If they pick up a mutation in the liquid biopsy, well, then you don't need to do the tissue biopsy. So there are, different combinations, permutations, but by and large, tissue is sent. But if the tissue is not available, you must always send the liquid biopsy for determining the EGFR and other driver mutations in the blood. Next slide. So this is the other, example where after the patient has been treated with EGFR TKI like, erlotinib or gefitinib, then when the patient relapses, so we should do the liquid biopsy, focusing especially on T790M, because 50 to 60% of patients will be harboring this particular mutation. And this can be tested either by ddPCR or by the NGS. So if that be so, well, then one can put these patients on the third generation TKI, which is the osimertinib. So I think a liquid biopsy in a patient who is progressing in EGFR mutation is very, very important. Next slide. So these are, again, you can pick up various mutations post osimertinib in FLORA study and AURA3 study. And these are patients who are, so you can look at the acquired EGFR mutations, for example, C797S. And, that can be sensitive to gefitinib, so again, you can look at the acquired amplifications in the MET or HER2, which can be sensitive to capmatinib, or today we have drugs like Enhertu. Similarly, you can have, MAP kinase and PI3K alterations, and you can have other acquired cell cycle gene alterations. So I think you can see EGFR, on-target mutations can happen, c-MET amplifications can happen, you can have second drivers in the MAP kinase. So I think these things can be detected in the tissue or in the liquid after a patient is progressing. So there are, limitations of cfDNA. The single nucleotide variants They detected well, for example, EGFR, KRAS, BRAF mutants, but then less utility in detecting MET amplification or rearrangements in the fusions of ALK, ROS, and RET fusions. So if liquid biopsy is negative for targetable genomic aberrations, it is required that we should do the tissue testing if you can obtain the tissue from the body of the patient. Next. So similarly, breast cancer, we do have data there, but then it's not as robust as in lung cancer. But then there are a lot of studies which are being conducted in that area for looking at various, genetic abnormalities in metastatic breast cancer. Next. So I think the most important test is looking at the ctDNA for detecting the PIK3C, and it detects 11 mutations, and this can help you to give the patient alpelisib along with fulvestrant after the patient has failed on the hormonal therapy. Next slide. So I think these are the plasma match trial studies where there is reasonable concordance, where you're looking at HER2 mutations or AK12 mutations when you look at the ctDNA, and the curves are, almost mirroring. So you can get similar outcomes looking at ctDNA for PIK3C, for HER2, and for AK2 mutations. Next. So these are the examples of ongoing studies where you're looking at rising ESR1 in patients who are being treated with CDK4/6 inhibitor. So this is a simple ESR1 which doesn't respond to the, you need to switch them to fulvestrant once the ESR1 starts rising. So which is another hormone, which is a estrogen degrader. And similarly, the INTERACT-1 is again a study to look at the presence of ESR1 variants, and you need to stop the AI and then switch them to fulvestrant. I think this test is also quite reliable and readily available with the lab. Next. So in early breast cancer, I think these are early days. A lot of studies are being done, but then we don't have, a robust data or validated data. But then, people are looking at ddPCR or NGS panels and the foundation labs, and Signatra assays are being developed after surgery, and to see whether there's residual disease or not. Next. So I think, you can look at these ctDNA in the adjuvant setting, as I've shown you, to follow up the neoadjuvant as to how the patient is responding. Post-neoadjuvant, we can do the monitoring at the time of relapse, and the patients who are metastatic disease, we can follow the VAF. So, these are various areas where the ctDNA can be applied. Next. Similarly, in prostate cancer, I'm just coming to the end of this talk. You can see prostate cancer is a long disease. They go through, no metastasis, which are hormone sensitive. Then they develop metastatic disease. So we keep treating them with various hormonal therapies, docetaxel and abiraterone, etc. And over a period of time, they tend to develop more and more mutations, and which is what the ctDNA can also pick up. Next slide. And the one such mutation in the prophecy study has been shown is androgen receptor V7 in the circulating tumor cells. And patients who harbor this mutation, they do bad than as compared to patients who are, negative for the ARV7. So this can predict the outcome of a patient who is, on chemotherapy. I think this is the last slide. So I think there is a lot of research and a lot of practical application of circulating tumor DNA with the introduction of liquid biopsy, which you can test with the various techniques, including ddPCR, NGS, and you can apply deep NGS, which is the cap sequencing in patients with the adjuvant setting. It can be a single and multi-gene ctDNA assay, as I just showed you, and for metastatic solid cancers, and the assays for detection of ctDNA relapse are currently, being evaluated. And as I showed you in the breast cancer and the KRAS mutations. So I think this field is exploding, I think, at this point in time, because the blood is available so readily. But I think the labs really have to up their ante to provide reliable data, and which perhaps is as good as the tissue. So, which is what I'm sure the lab Dr. Suruchi maybe shedding light on, because I mean, we are ready to if you tell us that there is 100% concordance or even better, so then we stop sending the tissue. We'll just send you the blood. We don't need to send the tissue all the time. So with this, thank you very much for this invite, and over to Dr. Sharu. Yeah.
Yeah, thank you, Dr. Sham. I think that was a really enlightening session, and I think we have had a lot of information and upcoming information around various tumor types and the use of ctDNA and various aspects of it. So now I would like to invite Dr. Suruchi for her session, giving us the laboratory experience, how what MedGenome has been experiencing in the liquid biopsy space, and how we have been working. So, Dr. Suruchi, over to you.
Yeah. Thank you, Dr. Sham. It was a very comprehensive overview of the applications of liquid biopsy, the one which are in practice or are going to be in practice. So actually, liquid biopsy has revolutionized genomics for the patients, especially where tissue testing is not possible due to inaccessibility of tissue sites or tissue being failed on next generation sequencing due to compromised quality of FFP DNA, and especially in monitoring the disease in the settings when the treatment has already been administered and we would like to monitor the relapse. So basically, I think this is very comprehensively discussed by Dr. Sham, and I will not go into it. So I'll just put one case. So in my talk, I'm going to emphasize certain points that Dr. Sham has mentioned in his presentation about the limitations and the laboratory aspects of ctDNA testing. So just starting with this case, which is a case of 58-year-old male presented with non-small cell lung cancer, adenocarcinoma stage 4. This gentleman was tested only for EGFR mutation by RT-PCR at the time of diagnosis, and no other test was performed. He unfortunately lost the block, a tissue block, and tissue was not available. When he presented to the clinic, he presented with massive pleural effusion, and he had progressed badly on first line of chemotherapy. So doctor had sent liquid biopsy test for actionable mutations in lung cancer. And what we found was EZR ROS1 fusion. So ROS1 fusions, as Dr. Sham has already mentioned, they are targetable and we cannot ignore them. They are to be honored, and the EZR ROS1 fusion, which was detected through liquid biopsy only, was honored. And there was a partial response within 3 months, 3 to 6 months. And here are the scans and X-ray, which is showing the response in this patient. And so basically, ctDNA testing has been validated now enough to detect single nucleotide variations, insertion, deletions with good sensitivity. For fusion detection, there is still a limitation that because the breakpoints of the fusions can be intronic. And when we are doing the fusion detection on cfDNA, circulating free DNA, so we have to include those intronic breakpoints in our panel. Unlike tissue testing, when we do fusion detection using RNA sequencing, exonic panel or exonic probes can detect both known and unknown partners for a particular oncogenic fusion gene. But in cfDNA, since the breakpoints can be intronic, so the panel has to be very carefully designed to include those regions for fusion detection. So that is one take that we have to always see, that whether panel is capable of detecting those fusions or not. So for example, ALK can have multiple partners. ALK EML4 is the most common partner, but it can have a partner like GCC2. So where only 4 cases are reported with that partner. And if liquid biopsy panel probe set doesn't contain the breakpoint at which GCC2 fuses with ALK. There is one clinical case report with the response as well for ALK inhibitor for this particular fusion. So liquid biopsy test may not be, detecting that particular fusion. So fusion detection, that is why I think Dr. Sham also mentioned that little less sensitivity for fusions, but definitely all common breakpoints, common fusions can be very well detected. And it depends on the amount of ctDNA in the blood, which I'll come a little later to that part. So this is about the concordance study Medgenome had published on lung cancer patient for exon 19 insertion deletion and exon and mutations in exon 21 of the EGFR gene, where high concordance of 96.96% between tissue biopsy and ctDNA was noted, with the sensitivity of 91%, specificity of 100%, positive predictive value of 100%, and negative predictive value of 95.6%, with the accuracy of 97%. So this was published in 2018, and from then onwards, we have done lots of samples on liquid biopsy, and this is a recent study that we are going to publish. I've just put one image of the paper that is ready to be published, where we have done a concordance study in metastatic castration-resistant prostate cancer patients, 65 patients, where tissue and liquid biopsy both were tested for HRR gene mutation analysis. And out of 65, 62 patients were concordant for HRR gene mutation results. Out of 62, there were 7 patients who had Tier 1 actionable mutation. And in 2B, the variant allele frequencies of liquid biopsy NGS and tumor biopsy NGS is actually represented here. And also the additional, what Dr. Agarwal also highlighted about that if we do liquid biopsy, we may get some more information. So there were 2 patients where the data is not shown here, where we got additional mutations than we got what we got on tissue biopsy. Plus there were 19 patients for which tissue biopsy was not available. So out of those 19 patients, also 4 patients had actionable variants represented in red block here. So that's the utility of liquid biopsy, that even if tissue is not available, we can still detect actionable variants through liquid biopsy if the representation of ctDNA is good enough in the blood of the patient. And this is one of those cases of prostate cancer where we monitored the response also to PARP inhibitor, where ctDNA was also tested and tumor was also tested. So in case tumor was not available for this patient, still we could, detect the HRR gene mutations through liquid biopsy, and we could have seen the results in the similar way. So apart from this, there are multiple concordance studies which are published in literature as well in different cancer types, in non-small cell lung cancer types, in 194 patients with 95% concordance, again in 229 patients of non-small cell lung cancer, and in breast cancer with overall concordance of 91 to 94%, and our very famous PROfound trial for prostate cancer, where 81 to 92% concordance was noted in about 491 patients, which were tested through tissue and tumor liquid biopsy both. So just to highlight certain points about which has been highlighted in ESMO guidelines for liquid biopsy testing, that the results on liquid biopsy can be negative, and these results can be negative because ctDNA is not represented to that amount in the blood of the patient that we are testing. So in those cases, they recommend that it should be noted as not detected. And if liquid biopsy results are negative, tissue biopsy is recommended to get the complete picture. However, if ctDNA amount is well represented, the positive predictive value of ctDNA tests is quite high. Plus, there are pre-analytical variables like what is the date of sample acquisition, or was there any treatment given, whether the patient is on or off the treatment at the time of acquisition. That should be reflected, and it may affect the result. For chemotherapy-treated patients, we recommend doing the sample collection after 2 weeks of chemotherapy administration, or ideally it should be done just before the chemotherapy cycle. then we may get potential germline variants on cfDNA, because this is the basically this is the DNA that is shed from the tumor or normal cells. So it may have we may get germline mutations, and therefore flagging these mutations as pathogenic or likely pathogenic mutations should be done with caution, and genetic counseling should be provided. Plus, confirmation on the whole blood is required for certain potential germline variants. Then there is a very known phenomena of chip clonal hematopoiesis, which can happen when we do liquid biopsy at higher sequencing depth, and low frequency variants can be due to clonal hematopoiesis in aged patients. So VAF has to be considered carefully while looking at such variants. So limit of detection and the assay limitations should be clearly noted by the lab, that what is the limit of detection. So for most of the liquid biopsy assays, 0.25 variant allele frequency is considered or validated as liquid limit of detection, but it varies from lab to lab. So it has to be clearly noted, and anything which is reported below limit of detection should be taken with caution. So some of the, like I mentioned, there are certain challenges or limitations. So one very important question that is asked is about low VAF variants. What is the reliability on low VAF variants? So I think Dr. Agarwal already pointed out safe sequencing methods, or we call it as a sequencing artifact correction using unique molecular identifiers. So just want to emphasize this point, that when we do the library preparation, unique molecular identifiers are used to tag the original DNA segments. So when these UMIs are used, the amplification error or amplification artifact, which is seen when we do the sequencing at very high sequencing depth, they can be collapsed, and these errors can be removed in the collapsed data. And collapsed data will have only the mutation which is represented by all the sequences. So this slide makes it more clear that true variants will remain. However, error can be corrected when we are using unique molecular tags to the original sequence that we are using for library preparation and high-depth sequencing. So because we are doing high-depth sequencing for liquid biopsy, there is a chance that these errors can show up like a false positive variant or a positive variant. So to minimize these errors, unique molecular identifiers are used while library preparation, and this gives us the true positivity rate. So again, I think this we have discussed. Yeah. So just the last slide, I mean, I think Dr. Sham has already answered these questions, that should tissue biopsy be done if liquid biopsy is negative? So I think the negative results are to be termed correctly as not detected, because it pertains to the amount of ctDNA in the blood. And one way that we can see that whether it is a true negative or not, that when we are doing a panel of genes and it is a monitoring sample, we may look at the driver mutation or a variant that is identified with high variant allele frequency in that particular sample. And the variant that we are looking for is negative, can be considered as true negative. For example, if we are testing a lung cancer patient and we get the driver mutation at high variant allele frequency, but we are not finding any resistance mutation, it can be considered that resistance mutation is not there, or maybe resistant mutation is at very low burden, which is undetectable by this particular test at this particular time point. And should liquid biopsy be used as complementary to tissue biopsy, or should both be done, and why? So again, Dr. Agarwal has emphasized this point, that combining liquid biopsy and tissue testing, it captures the heterogeneity and can be highly sensitive without compromising the specificity. So obviously, when we do both, we can have the information from multiple metastatic site, genomic information, and tissue is quite localized tissue biopsy, so may miss some of those low variant allele frequency variants which can be detected through liquid biopsy. And if liquid biopsy is negative, then tissue testing should be considered for that patient. Thank you so much. We can take up question and answers now.
Yeah, so we have one question in the chat box, which is there any role of liquid biopsy in unknown primary cases, like carcinoma of unknown primary? So, if Dr. Sham, if you can.
Yeah, absolutely. So I think in a patient where the primary is unknown, by doing the liquid biopsy, or even for that matter, the tissue biopsy sent for sequencing can pick up an actionable mutation, so which could be very, very helpful. So if the tissue is not available in a patient with unknown primary and the patient has metastatic disease, so I think a liquid biopsy would be in order to pick up any actionable mutation. And for example, if somebody is found to be having an EGFR, exon 19 deletion, so then that is a pointer towards a lung primary, so that can also give you a hint towards primary. But as I showed you in one of the slides, a lot of these tumors have common abnormalities because HER2, for example, can be amplified or mutated in a variety of cancers. So P53, PIK3C, and so on. So you may not be able to tell the primary, but then you can get onto a actionable mutation.
Yeah.
Dr.
I think there is a new updated trial in ESMO also, CUPSCACO trial, where they have established the role of liquid biopsy in carcinoma unknown primary. So the next question is from Dr. Prabhakar. He's asking, can we do liquid biopsy for liver cancer for early detection?
Dr. Suruchi?
Liver cancer for early detection.
Yes, I think if we do liquid biopsy for liver cancer, there are two things to it. Early detection means like, just like GRAIL or something like that, looking for tumor signatures in the, before even the cancer has developed. So if we are looking at that particular aspect, then it is not on the shelf as of now and still in the exploratory mode. But if liver cancer is already there and radiologically established, we can look for mutation analysis using ctDNA or liquid biopsy testing. But if the cancer is not yet developed and we want to look at certain signatures using fragmentomics or some particular signatures, that is not on the shelf as of now.
Right. So, at the moment, when you're talking of detection of early any cancer by ctDNA, I think that is evolving quite rapidly. So it is not prime time at this point in time. You have these certain tests like Signatera and a few more labs which have popped up. And they've also, for example, in colon cancer and urinary bladder cancer. So they're not available and they're very expensive at this point in time. And they also they're not one-time tests. One need to follow them up every 3 months or so to see the WAF and how the mutant clones are evolving. So I think the cost is a deterrent. Dr. Suruchi can tell the technology is also required to be more validated, I guess. So maybe Dr. Suruchi can tell on her project on colon cancer, which we marked on.
Yeah, so we need to have proper reference models to, get the accurate results on such tests. And if we want to detect any cancer early, we have to have a tumor-specific data. So like Dr. Agarwal mentioned that Signatera has worked on colon cancer and on breast cancer and some bladder cancers also. So I don't think as of now, today, as of today, we are in a position to call it as a reliable test to, early detect the cancer based on certain cfDNA signatures.
Okay, so the next question is, I think it's more of a patient-related thing. If we find any new alteration while doing a liquid biopsy, how to react, because sometimes patients do become, they can create panic about it. So it's more of a patient handling. I think that really depends on the clinician and the counseling which is done before sending the test.
Right.
Yeah.
So, Dr.
So,
Charu, so if there's a new alteration which is being picked up, so normally what they say is uh, you need to follow that up. Look at the variant, allele frequency, whether it is rising or not. But if you are picking up new alterations, so they are usually, they happen before, and the clinical and the radiological appearances of metastatic disease in a patient who is being treated with chemotherapy. So these alterations will happen, 6 months, 9 months earlier. So you
before.
don't need to kind of panic at this point in time, and it is not so this means that the tumor is evolving and acquiring new somatic mutations which are being detected on the liquid biopsy. So one has to be careful, but then you don't have to jump onto it, or you don't have to, unless the patient is deteriorating. So if the patient is deteriorating with that new mutation, then you have to figure out whether that mutation is actionable. Then it can be targeted. If that patient has radiological progression, then of course one has to treat, the clinician has to change the existing line of treatment, and the chemo, radiation, whatever is required should be given. So it depends on the patient's condition at that time.
Yeah, I think that is a very important aspect of it, which is answered in a very normally asked question. So the next question is, if there are conflicting results between liquid biopsy and tumor biopsy, which one should be used and what parameters should be taken into consideration?
Yeah.
So,
So basically, I think tumor biopsy is still considered as gold standard. However, liquid biopsy can basically, detect extra mutations than tissue biopsy in certain cases when the representation of ctDNA is from different metastatic sites and any evolving mutation or very low frequency mutations are represented with some metastatic sites. But we have to see what is the actionability in that particular report. And accordingly, we have to take the decisions. Dr. Sham, I think you can maybe add to it.
Yeah, so I think by and large, the driver mutations are kind of exclusive. So usually, if somebody has EGFR mutation, less than 5% patients are going to be having other actionable mutation. So, but for example, we have a patient right now who had, EGFR mutation and BRAF mutation, and the VAF of the BRAF mutation was 20%, whereas that of the EGFR was 7%. So we did counsel the patient, and we combined with the EGFR TKI with say a MEK inhibitor, and after 3 months or 6 months, the patient is in complete remission. So I think one needs to individualize on patient-to-patient basis as to what are the mutations seen and what is the variant allele frequency.
yeah. So the next question is, what possible biomarkers can a liquid biopsy detect? Is PDL1 possible on a liquid biopsy platform to detect? We can also talk about other immunotherapy biomarkers like MSI and TMB in answering that. Yeah. So, Suruchi, you can, yeah.
Yeah. So basically, PDL1 biomarker as such cannot be detected through ctDNA mutation testing. We can still look at the gene mutation, CD74 expression through, ctDNA. Expression we cannot see, but the mutation we can see, or amplification we can see through ctDNA, which will give us an idea of what is the, PDL1 status. But it is not a very established method that we use. And some labs, they do PDL1 testing on circulating tumor cells, but that is also not guideline recommended. So I'm not sure how it is used in clinics for actionability. Probably Dr. Sham can tell us more about it, because we know that CTC can be tested for PDL1, but that is very low amount of cells that is present in the blood, usually 1 or 2 cells. So how good they are to be considered as clinically relevant?
No, so clinically, I think by and large, we use PDL1 testing on the tissue. For
Yeah.
the lung, we use the TPS, that is the tumor proportion score. And for today, I think for a large number of solid cancers, it is CPS, where you have the composite or the combined positive score in which the tumor and the tumor microenvironment PDL1. So it's all on the tissue as an IHC. So I think liquid biopsy or NGS, etc., is perhaps not the answer at this point in time. In terms of, you asked the TMB and the MSI. So MSI, again, to begin with, what we're doing is four proteins, MLH1, MSH2, MSH6, and PMS2. And if they are found to be missing, so that would mean there is a loss of expression of these genes. And if you need to confirm, one can do PCR, and or else one can do NGS, which is usually done from the tissue. I think Dr. Suruchi can tell whether you can do liquid biopsy NGS to have the MSI, figured out.
Yeah, sure, doctor. So we can do MSI detection through liquid biopsy by using certain signatures, which can actually, so basically it is NGS-based MSI detection. And it is useful in the patients where, tissue is not available, or in advanced metastatic cancers where MSI testing is warranted, but biopsy is not possible or tissue is not available. So MSI by NGS can be considered. As per recent guidelines for MSI testing, MSI by NGS is accepted if it is quite well validated. However, MSI by PCR is on the tissue, is very well accepted for all the tumor types except endometrial. In endometrial, still they would recommend to do MMR by IHC for those 4 genes for loss of expression. So based on the guidelines, yes, NGS can be used if tissue is not available.
And I think for TMB, you need a larger number of
panel size. Yeah. So if it is
300 plus genes need to be looked into, which I think are not possible with the liquid biopsy, right?
So liquid biopsy nowadays, when we have a 500 gene panel or 500 plus gene panel, we have a good sized panel greater than 1 MB. Then we can determine TMB through liquid biopsy also, as how we do on tissue biopsy, basically.
So is it readily available? I mean, the larger panel, the liquid biopsy panel.
Yes, sir, it is available. It is called as comprehensive genomic profiling through liquid biopsy, where 500 plus genes are tested for all of these biomarkers, just like how we have a comprehensive tumor panel. So similarly, it is also available.
Yes, sir. So the next question is, liquid biopsy is organ specific, or a common panel of gene can be used to diagnose cancer of all types, or to be used in cancer of all types?
Should I take it up?
Yeah.
So basically, it is a very good question, I mean, so before, we send the liquid biopsy test, we need to understand the objective of our testing. We need to understand what stage the patient is in and what are we going to get through this testing. So that's how we can decide, right, that whether we want to go for a hotspot panel. Like, for example, if we are just looking at resistance for tyrosine kinase inhibitor, probably we are interested to look like what are the resistance mechanisms, and we would look basically maybe a lung NGS panel through liquid biopsy. Or when we are looking at carcinoma of unknown primary, like there was a question, so there we would definitely would like to have a comprehensive liquid biopsy panel where we may have certain mutations which may help us to diagnose that particular cancer type. So there are multiple options available, whether it is organ specific or it is like a comprehensive panel. We have to decide based on what are we going to, do with the results, basically.
Oh, yeah. So how do you oversee the liquid biopsy space evolving in the future in terms of technology and clinical use? So I think a snapshot of it is to basically from the early detection to the disease monitoring. We can elaborate it on little, Dr. Shyam, if you can.
Yeah, so I think currently we are using mainly for detecting actionable mutations in a patient with metastatic disease. So I think that is where it finds the commonest use. But I think the stage is set for looking at minimal residual disease through liquid biopsy in a patient who has undergone definitive therapy in the form of surgery, radiation, say a colon cancer, as I showed you, stage 2, 3, who has been operated. And the final thing is, so that's we're talking about DNA. So I mean the mutations. So when you're looking at DNA methylation, so there you're looking at early the GRAIL study, which Dr. Suruchi was referring to. That's a different methodology, which is again I think which will require even a longer time to evolve, which I wish it can evolve early. But so the present technology is okay for detecting mutations in metastatic disease, but you need deep gap sequencing, etc., for early cancers.
Yes, sir. Next question is, can we use urine as the major source of ctDNA or cfDNA in pancreatic or renal cell carcinoma? Any insights on that, Dr.
Yeah, I
Shah?
think one can use any fluid, but you have to standardize the testing and validate that test, whether it is pleural fluid or CSF or urine. And I think there are ample reports looking at these kind of studies. But I think the lab has to perhaps dedicate to that area so as to pick up the ctDNA from that particular sample.
I think we have Dr. Ram also in our panel. Dr. Ram, would you like to shed light on this question? Okay, I think maybe we can move ahead.
Okay. So apart from early detection or cancer screening, is there any other scenario where liquid biopsy can be taken up with caution or is not recommended? So, this is a scenario of early detection or cancer screening. Other than that, is there any other scenario where liquid biopsy should be taken up with caution, particularly?
I think we've already answered this. So I think
I think.
biopsy is done mainly in the metastatic setting and evolving in early stages.
Yeah, Dr. Suruchi, the next question is, what are acceptable variant allele frequencies in liquid biopsy to be considered as an actual detection of mutation? So,
Sure. So basically, like I discussed, the use of unique molecular identifiers has helped us to reduce the sequencing artifacts to minimum, and the accuracy has improved with this advanced next generation sequencing technology that we use. So the validated variant allele frequency or limit of detection of variant allele frequency is about 0.2 to 0.25%. And anything above 0.2% that is reported can be considered as a true positive. Sometimes we do get very low frequency mutations, which can range from 0.1 to 0.2. And if they are actionable, driver mutations, especially in relapsed cases, we do report them with caution as well. So as per the validation and with the use of UMIs, I think 0.2 to 0.25% variant allele frequency can be considered as the limit of detection and are acceptable.
yes. So next question is, how to explain the patient about the rejection of sample? In terms of if the cfDNA testing has failed or profiling has failed.
Yeah, so I don't see the liquid biopsy samples being rejected very frequently, only in very rare cases when we receive hemolyzed sample. In those cases, we are not able to do cfDNA assay. And because hemolysis will lyse the cells and genomic DNA representation will increase. So, and that can be actually, physically examined that whether the sample is hemolyzed. So plasma will be colored, and usually in those cases, we send the rejection of samples, and that is very, very rare. We don't experience that very often. So usually cfDNA tests are not rejected so frequently.
Okay. The limitations of RNA component in the liquid biopsy setting, analyzing the RNA component.
Dr. Shah, would you like to take it up?
I think it's better if you answer this.
Yeah, sure. So basically, when we do liquid biopsy mutation testing, we are utilizing circulating cell-free DNA. We are not isolating RNA. RNA is a labile molecule, we all know, and there are limitations to isolate CFRN. It is not that we cannot do it. We can do it, but there are no, there are limited studies and guidelines are not there for CFRNA testing as of now.
So the next question is, does the location, that is the proximal site or to primary tumor or to the metastatic site, matter in liquid biopsy, or does it impacts the detection rate by any chance?
I think the question is not clear. What do you mean
So
by
basically, what I can interpret from the question is that if the location of the metastatic site is proximal to the primary tumor or it is far away from the primary tumor, does it impact the detection rate of
no,
mutation?
I mean, I think it depends on the ability of any tumor to shed
Right, sir.
ctDNA into the peripheral blood, the proximity to the, so I now understand the distance between,
Primary site and the metastatic
and
site.
so I think that is not going to make any difference. So
Mm.
as long as the tumor has a potential, which I showed you, for example, the colon and breast and the others, they have almost 100% patients will have ctDNA, whereas prostate and, certain
Gliomas.
thyroid and gliomas, the brain tumors, so they have a lower propensity. So I think it is the tumor type which is more important than the
And the
distance
distance
between the
between
primary
the.
and the secondary.
Mm, yeah, I think that was an interesting question, although. Yeah, so we have almost answered all the questions. If there are any comments from anyone in the panel, or Dr. Sham and Dr. Suruchi, if you want to comment and close it up.
So practically, NetGenome is offering today a liquid biopsy panel of say 50 genes at this time. So what is on the offer?
So we are offering 117 gene panel for SNVs and indels, and we are also doing fusion detection for 15 genes. We are also offering comprehensive genomic profiling through liquid biopsy, as you asked.
As you
So
mentioned.
we are offering 500 gene panel, which detects single nucleotide variations, insertions, deletions, fusions, copy number variations, TMB and MSI. TMB and MSI as immunotherapy biomarkers. This is done under single test. And we do offer some tumor-specific panels also, like LungTrack Advanced Lung Cancer, where 24 genes are screened basically for actionable mutations. So this has all the genes which are recommended as per NCCN guidelines.
So this is all in the metastatic setting, right?
Anything, sir, at upfront also it can be used.
But in a metastatic cancer, in a patient who has metastasis from lung cancer, right?
Yeah, if it is a stage 3 or stage 4 disease,
right.
in those scenarios. Yeah, usually with stage 1 and stage 2, we may not have good diagnostic yield.
Great. So I think it so appears that.
Just one point to add, sir. We also have HRR liquid biopsy test. So that's what I showed the data for prostate cancer.
Right. You showed that.
Yeah, and advanced breast cancer panel for PIK3CA, ESR1, PTEN, and AKT1 for hormone positive. That is also we have recently come up with.
So I think before it ends, I need to ask Dr. Suruchi the future of the liquid biopsy. So how do you foresee your lab and maybe worldwide?
Definitely, sir. Liquid biopsy has a very good potential, and I think we have come so far when we were, doing amplicon-based sequencing for liquid biopsy samples, and now we are doing hybrid capture. Use of UMIs has reduced sequencing artifacts, high sequencing depths, and with advanced technologies, we are now able to produce quite accurate and reliable results. And a lot of experience we have gained, and there is a lot more to do. So liquid biopsy has a very good future. And yes, of course, people do debate that can it replace tissue biopsy? So of course, it is non-invasive, very easy to do. The cost of sequencing can be a little higher than tissue biopsy at this point of time, but I think we have a way forward to it. Yes.
Thank you.
Thank you so much, everyone, all the panelists, and also I would like to thank all of the participants who have attended this webinar, and it has been really great, and we have had quite a good, interactive session. So thanks everyone, and have a very good night, and keep smiling and keep sequencing. So thank you. Have a good night.
Thank you.
Thank you, Charu. It was
Bye.
wonderful moderation. And thank you, Dr. Shyam, for joining us.
Thanks.
It was a very warm participation from your side.
Thank
Thank
you.
you so
Thank you,
much.
sir.